Infectious endocarditis is an infection of the endocardium. Most commonly affects the heart valves. It is an infection that occurs on the edges of the heart valves known as vegetations. It is clinically useful to consider IE in terms of the type of disease, the organisms responsible, and the valves involved. Acute IE develops suddenly and may become life-threatening within days. Subacute develops slowly over a period of weeks and several months. Prostatic endocarditis occurs after a valvular surgery. It's good to remember that while many microorganisms can cause IE, most are caused by a few bacterial species of streptococci and staphylococci. In acute settings, if the patient acquired it in a hospital setting, it is due to Staph aureus. If not, then it's due to streptococcus. Subacute settings are usually caused by S. viridans. Prostatic endocarditis is classified into two: either early, which is less than 60 days post-surgery, caused by coagulase-negative staph or CONS, and late, more than 60 days post-surgery, which is usually caused by S. viridans. Generally speaking, 75 to 80% are caused by strep and staph. About 5% is caused by fungi, and the remaining are by a group of gram-negative bacilli known as the HAC group. Let's review this from microbiology. HAC stands for Haemophilus, Actinobacter, Cardiobacter, Acanella, and Kingella. All valves are susceptible to infection. Right-sided IE involves the tricuspid valve and the pulmonic valve. Although this has a 10% prevalence, it's very common in IV drug users. Overall, the most commonly involved valve in the IE is the mitral valve. Among other predisposing factors such as congenital cardiac lesions, rheumatic heart disease, or having degenerative valvular diseases, the incidence of IE is proportional to the pressure gradient involved in the various valves. So we already know that left side has a higher pressure compared to the right side. So the prevalence of IE in the left sides are as follows. Mitral regurgitations work in systole, where the blood goes from the left ventricle to the left atrium. The blood has to be pushed back in the opposite direction, causing the highest pressure gradient. Mitral stenosis works in diastole, and because the heart is relaxed, there is a low pressure gradient. So the highest incidence of IE is with mitral regurgitation or prolapse, and the lowest would be the path of minimal resistance, from the left atrium to the right atrium in the ASD. So let's look at the pathogenesis. It's an infection caused by a bacteria that enters the bloodstream and settles in the heart lining or heart valve. A mass of fibrin, platelets, and infectious organisms combine to form vegetations along the edges of the valve. Each time the valves open and close, there's a chance the vegetations will break and embolize into the systemic circulation, causing an inflammatory response. This will result in the patient having fever, chills, and rigors. Wherever the embolism goes, there will be an abscess. If it's lodged in the spleen, then you get a splenomegaly. Brain embolisms can cause a brain abscess. These bacterial growth can grow into an abscess that can later perforate into the valve. The perforation allows blood to regurgitate, causing a new onset murmur. Mitral valve regurgitation is most common in non-IV drug users on the left side. Tricuspid regurgitation is more common in IV drug users on the right side. A Duke criteria is used to diagnose a patient of endocarditis. The above symptoms are not considered diagnostic. So let's break down the criteria to make sense of it. So the major criteria involves doing an endocardiography, which identifies vegetations and the underlying valvular dysfunction. This is important as an initial vegetation can progress further into an abscess or be an oscillating piece on the valve, or could even damage or perforate the valve, even a prostatic one. Echoes also help identify a new valvular regurgitation. The second criteria involves a positive bacteria culture. A blood culture is taken, usually in sets of 3, and you need to have the same organism positive in majority of the cultures. These samples are taken at different times over 24 hours and are done before an antibiotic treatment is started. Serological tests may be helpful with identifying Coxiella burnetii, which causes Q fever and is transmitted by animals but is quite rare. Minor criteria includes having a predisposing heart condition, abnormal valve, or an increased risk to infection. Fever is seen. Minor criteria also includes vascular phenomena such as an infectious arterial or pulmonic emboli. Pulmonic emboli can be caused by right-sided endocarditis. You can also have a mycotic aneurysm, intracranial hemorrhages, and Janeway lesions. Immunological phenomena can cause glomerulonephritis. In blood vessels, it can produce osseous nodes and Roth spots. These depositions can also produce an increase in rheumatoid factor. Janeway lesions are painless macules on the palms, whereas osseous needles are tender, painful subcutaneous nodules on the fingers. Roth spots are retinal hemorrhages that can also be seen in other diseases such as lymphoma, leukemia, and sometimes in anemia. Rheumatoid is seen due to immune complex deposition. Due to glomerulonephritis, microscopic hematuria occurs in 70% of the cases, but acute kidney injury is not common. Positive blood changes and positive echocardiograms that don't satisfy major criteria are also considered. So when ordering for labs, you want to do a culture or a serological test to identify the causative agent. A normal echocardiogram, although can be ordered, usually misses small vegetations, so a transesophageal echocardiography can be ordered as it's more sensitive. Chest x-rays may show a heart failure or evidence of a septic emboli in the right-sided endocarditis. ECG may show an MI if an emboli went to the coronary circulation, or conduction defects if the infection extends over to the septum. Blood counts show a normocytic and normochromic anemia with a raised ESR and often a leukocytosis. Metastatic abscesses can lead to splenomegaly, and urine stick testing shows hematuria in most cases. So for diagnosing IE, the patient has to satisfy 2 major criteria, or 1 major and 3 minor, or 5 minor criteria. So for treatment, early empiric 4 antibiotic treatment is usually given for acutely ill patients, which is vancomycin and gentamicin. The prognosis for prosthetic valve endocarditis is actually poor. Pre-procedure prophylaxis is encouraged, but is only indicated in patients who have significant cardiac defects or are undergoing high-risk procedures like dental work involving the gingival tissue. The preferred antibiotic prophylaxis is amoxicillin. So as a summary, a good mnemonic to remember is from Jane. F for fever, R for Roth spots, O for osseous nodes, M for murmur, J for Janeway lesions, A for anemia, N for nail bed hemorrhage, and E for emboli. Also to note, it requires multiple blood cultures for diagnosis. If the culture is negative, it's most likely due to Coxiella, and there is also the hack species that can cause infective endocarditis. Mitral valve is the most frequently involved. Tricuspid valve endocarditis is associated with IV drug abuse. There's one other form of endocarditis. Libman Sacks is a non-bacterial endocarditis that is associated with lupus. It is one of the most common heart-related manifestations to lupus, the most common being pericarditis. So Libman Sacks endocarditis can involve in any surface of the valve, but it has a predilection for the undersurface of the valve. Now these sterile vegetations have only fibrin in it. Because of their location, they can damage the chorda tendina, and in turn can damage the function of the valve, causing mitral regurgitation. So a patient would come in with mitral regurgitation and maybe pulmonary edema and lupus. But normally you would give steroids for lupus, And for vegetations, you would give antibiotics. But because there is no infection, you don't need to give antibiotics. The treatment of choice is valvuloplasty.